Registrar sir. Good morning, Dr. Dinesh. Please start.
Yes, sir. Good morning, everyone, and I welcome you on the behalf of IIP Delhi office in this fifth Master E-Class Pediatric Nephrology session. And this is going to be a wonderful session. And today's topic is on approach to hematuria. And the speaker is none other than Dr. A.S. Vasudev, sir, former chairperson of the nephrology chapter. And the chairpersons with us is Dr. Subhankar from Calcutta and Dr. Sandeep from Safdarjung Hospital. And before that, I would like to announce also that next month we are having our state annual conference, PCNI 2026. And I request each faculty to please facilitate their postgraduate students to register for the conference. And Dr. Neha Bandari has created this e-nephrology sessions, and she has done a wonderful job. I must congratulate her for this wonderful work. Thank you so much. And now hand over to Dr. Ajay Gupta, sir, our president, IIP Delhi, sir. Thank you, sir.
Thank you, Dr. Dinesh. Good morning, respected faculty and dear delegates. Today we are lucky to have Dr. Vasudev sir, who is one of the pioneers in pediatric nephrology in India. He has been the past chairperson of the nephrology chapter of IIP and vice president North Zone of Central IIP. And we are thankful to Dr. Shubhankar and Dr. Neha also. We also welcome Dr. Kanavanand sir and Dr. Selva Kumar. They are again young doyens in pediatric nephrology. Without wasting much time, I request Dr. Neha to please introduce the chairpersons and the speaker.
Thank you very much, sir. First of all, welcome all, and a big thank you to IIP Delhi for organizing such a good program that has been going on for a few weeks now, and we get really great input on this program. So I would like to welcome our chairperson. Dr. Kaval is not here right now, so I think once he joins, we can welcome him. He's heading Department of
Sure. We continue with Dr.
Shubhankar.
Vasudevan.
Okay, so I would like to welcome Dr. Shubhankar. Dr. Shubhankar is an expert today. He's a throughout Insonian with his fellowships from AIMS Delhi as well as from NUH Singapore. He has been an author at various written chapters in various books, has lot of international as well as national publications. He has served in various capacities in the editorial boards as well as a zonal representative of ISPN. He has received various awards, which includes OP Ghai Medal in Pediatrics for Best Senior Resident, as well as currently he's serving as an Assistant Professor Pediatrics at AIMS Kalyani. So welcome, Dr. Shubhankar.
Namaskar. Thank you so much.
We have our speaker, Dr. Vasudev. Sir doesn't need an introduction. We all know him. He's one of the pioneers of pediatric nephrology in India. He is a senior consultant currently with Indraprasth Apollo Max and Holy Family Hospital. He has also served as a chairperson for IIP nephrology chapter in last year. He has also served in various capacities as national vice president, vice chair, Pediatric Kidney Foundation. He's also a visiting faculty currently in MCW USA. He's also written books in pediatric nephrology. He's the editor-in-chief of IAP Textbook of Pediatric Nephrology, as well as editor of Algorithms in Pediatrics and Textbook of Radiology. Various honors, awards. There's a long list of awards that he has actually received, right from V. Gopal Award of IAP Best Paper, Sarla Vaishnav Award of IAP Delhi Best Paper, Young Scientist Award of Department of Science and Technology, Puneet Sharma Oration Award awarded 2020. He has also done Dr. Gopal Saran Oration at Bihar Pedicon 2019 and AP State Oration at Vijayawada in 2023. He has multiple publications. So without wasting much time, over to you, Vasudev sir, so that we can hear golden words on hematuria from you.
Thank you. Thank you very much. And at the onset, I would like to compliment IIP Delhi under the leadership of Dr. Ajay Gupta and Dinesh Goel and the team for carving such nice programs, not only nephrology, but so many other programs in Delhi that I wonder how do they find so much of time to have so many programs, and they are going like a jet speed. So congratulations to both of them and the team, and also Dr. Neha Bandari for taking the initiative of bringing the pediatric nephrology at the forum of IIP Delhi and National Forum, and so much of hard work she is putting in. So, as already declared, I'll be talking about red urine in children, and this basically means hematuria. So, I'll spend about half an hour, and then we can have some queries, questions. I have based my talk mainly on practical aspects, which is very useful for pediatricians rather than going into a lot of theory and papers and publications and research work. Because in day-to-day practice for pediatricians, what is required and what I've learned in my last 41 years of pediatric nephrology practice, I try to put those into the slides today. So I can share my slides with the permission of chairpersons and the organizers. Okay, are they full screen slides?
Yes, sir.
Full screen, fine. So the topic, as I already said, is a child passing red urine. That is the most common complaint when the parents come. They don't know what the cause is. And then for pediatrician, that means how do I manage it? That is hematuria in children. Right. So when the parents and grown-up children, they see the red urine, they get scared because to them red urine means that this is basically hematuria, and this is blood in the urine. And the scare itself leads the patient or the child to come to the doctor. And if we see the incidence, we encounter gross hematuria in 1 in 1,000 children, but microscopic hematuria is much more common. 1 in every 100 children, we can find microscopic hematuria. Now, what are the goals for our learning for our pediatricians friend today? So it is first to recognize and confirm the findings of hematuria, then to identify common etiologies and treat them at your clinic or hospital under your care, and then to select those patients who have significant urinary system disease that might require further expertise or referral. And as we go down the line, you will see that there are some cases who need a referral with pediatric nephrologist and which are the ones which can be treated at your clinic. Now, once we see gross hematuria, there's hardly any confusion in that, generally recognized with the naked eye because the color is bright red and we can figure it out. But microscopic hematuria, we would say when there are 5 or more red blood cells per high power field on microscopic evaluation of urinary sediments from 2 of the 3 collected urine specimens. And this also, I would say that if you have in one specimen, do not jump to the conclusion that the child has some renal problem. Wait for a week or two and then again see if the hematuria or the RBCs persist. These are the ones which need to be further investigated. Now, how does the child present with blood in the urine? If it's a gross hematuria, then it can be passage of dark or cola colored or smoky urine, and normally they would bring the sample sometimes along with them, and you can figure out that this is gross hematuria with the color. Then other times you can find urinary or other symptoms are there with incidental finding of microscopic hematuria. But at times during routine analysis of urine, you have done the urine examination for something else as a part of detailed investigation for another disease, and you find hematuria. So these are the different ways in which you can detect blood in the urine. And even a small quantity of blood, even up to 1 ml, I'll show you the figure, that can appear red in the mildly red in color, which can scare the parents. But there are certain substances, several substances which can discolor the urine, which can simulate hematuria, and we'll look into what can be the causes of those. Now, I wanted to show this picture because see, if we add 1 ml of this 1 ml of blood, it gives a tinge of reddish color. But if there are 2 or 3 or 5 ml of blood in 1 liter of urine, it can really scare the parents or the child that it is totally red and there's blood in the urine. So, but what you have to tell the parent that this color does not mean that the child is just passing blood only. This is mixed in the urine, and it may be just a small quantity of maybe 2 ml per liter, which is causing this color. So don't get scared. We will look into it and we'll find the reason for it. Now, if we see that all that is red is not blood, and there are other causes of red urine, and what can be the other causes? Let us see them also. Red or pink urine can be true hematuria, but it can be because of the free hemoglobin or myoglobin. I'll show you a case in that. Then it can be because of the urates. Certain drugs can cause pink or red color urine. Beet is very common, and it can sometimes lead to that red color, which can scare the parents, or sometimes red dyes in the foods, and porphyrin can also cause urine to be red. At times there is dark yellow or orange urine, which is again mistaken to be a red urine. This is normal concentrated urine, or it can be because of certain drugs like rifampicin, pyridium, NFT. So when we prescribe these drugs, we have to tell the parents that the urine color will change, so don't get worried about that. But sometimes there may be dark brown or blackish urine, which may be because of methglobinemia, bile pigments, metronidazole, alkaptonuria. And I've also seen a child with green urine. And if time permits, at the end, I'll tell you the story of this green urine. And it was amazing. So if we look into the pathophysiology, how does the blood come into the urine? It could be because of the structural disruption in the integrity of glomerular basement membrane, which is caused by inflammatory or the immunological process, or it could be because of the toxic disruptions of the renal tubules, or it could be because of the mechanical erosions of mucosal surface in genitourinary tract, whole of the urinary tract. If there's some mechanical erosion, it can create a blood in the urine and cause reddish colored urine. So once you see a red colored urine, we have to assess for the red flags, and these are very important. If any of these are present, they need urgent evaluation and at times referral also for a consult with a pediatric nephrologist. If there is proteinuria along with hematuria, if there is hypertension, edema, elevated creatinine, oliguria, or there's a family history of renal disease, or there are other systemic symptoms like rash, joint pains, prolonged fever, these are the red flags which you should not miss. And I've seen children coming to me, patients coming to me, when they had one of these findings with the red urine, and they have been lingering on with this problem for weeks and days and missed the diagnosis of the cause of hematuria. So look for these red flags when you have red urine. Then what are the non-serious causes of hematuria in children? Could be urinary tract infection or exercise-induced hematuria. Minor trauma can cause hematuria, viral infections, fever and dehydration, again very common causes of microscopic hematuria, menstrual or perineal contamination, benign familial hematuria, idiopathic microscopic hematuria. So these are the causes where there's not so much of scare, and these are, I would say, not very serious causes, but they need to be evaluated. Then be careful about the serious causes of hematuria, because these are the ones where renal damage can occur and long-term complications can occur, and we have to be very cautious. And these can be either renal or glomerular erosion, post-infectious or post-streptococcal glomerulonephritis as underlying cause, IgA nephropathy, renal vasculitis or lupus nephritis, Alport syndrome, hemolytic urine syndrome. So these are the glomerular causes, which are serious ones if there is hematuria present. But there can be other structural or other anomalies like nephrolithiasis, congenital urinary tract anomalies like Kakut, any tumors, especially Wilms in children, bleeding disorders, or child is on anticoagulants. There are vascular malformations, and one of them is nutcracker syndrome. So these are the serious causes of hematuria which should be looked into whenever the child comes with red urine or gross hematuria. Now I'll come to show you a case which was referred to our ER, and this was a 6-year-old child referred from a nursing home nearby, and the history of there was history of passing red color urine and oliguria. Renal parameter was deranged and blood pressure was high. Fortunately, they had taken the blood pressure there. The history was the child had fever and upper respiratory infection and was given some medication by the local pediatrician, general pediatrician. So our provisional diagnosis was that probably the child had acute glomerulonephritis, and the laboratory investigations were sent accordingly. Urine examination, blood counts, kidney function test, ASO, complement level, chest X-ray, and so on and so forth. And over the next 24 hours, urine output started decreasing further. So this was a little problematic child, and this is how the color of the urine was. It was like a smoky or dark colored urine and high colored urine. So on examination, the blood was present in the urine, but on microscopic examination, there were no RBCs. So what does that mean? The blood is present, but no RBCs. That means this is not true hematuria. This could be because of other causes, as I said, because of hemoglobinuria or myoglobinuria. Further, the oliguria increased, the kidney functions deranged further, there was fluid overload, supportive care was given, the child needed hemodialysis for next 5 days, and there was recovery after 10 days. And at the end of that, when investigation was done further, this child report came as G6PD deficiency. So this was a case where there was a red colored, high colored urine, typically mimicking acute glomerulonephritis, but the blood was present in the urine, but there were no RBCs, and that led us to a suspicion that it is a non-glomerular problem, and this was hemoglobinuria, and this was because of the G6PD deficiency. So when we see a child with hematuria, we first do the screening test, and best screening test is to do a urine dipstick which identifies heme protein, which is a very sensitive test, and specificity is also 99%, and it can detect up to 1 to 5 RBCs per high power field. So once we have detected, this is how the urine dipstick looks. And you see that if it is positive, it will give a color like this, and this is blood, and you can see the range of blood present. This is positive and negative, and once you have suspicion of blood in the urine, then you have to send for microscopic examination, and if there are more than 5 RBCs per high power field, we would label it as hematuria. And if the urine dipstick is positive but there are no RBCs, then it could be hemoglobinuria or myoglobinuria. I'll not go into the details of both these conditions. It will take a full lecture in itself. But other confirmation, other information, when we send the urine for examination, we would request the laboratory or the pathologist to look for dysmorphic RBCs. And if there are more than 20% dysmorphic RBCs, they are very significant. And RBC cast also sometimes may be seen in the microscopic examination. So the point here is that once you have blood in the urine, you do a dipstick test. If there is blood, then you do a microscopic examination. If there are RBCs, true hematuria. If no RBCs, the direction entirely changes to other conditions like hemoglobinuria and myoglobinuria. Now, once you have a child with red urine, very important that certain points in the history has to be elicited. And trust me, just by taking a good history, you can figure out where the problem is lying. And I'll show you what are the clues in the history which can lead you to a tentative diagnosis. Just ask whether it's a single episode or recurrent, because it matters if the child has got recurrent hematuria, whether it is painful or not, how's the urine output, any oliguria. Is there any urinary discomfort like dysuria? Was there any history of fever, rash, joint pains, headache? And each of them has got an importance. If there are any puffy eyes or edema legs, is there a family history or any other member having hematuria? Any history of stone disease in the family? Any history of bleeding diathesis in children? I normally ask them if there's any cut or wound, does it bleed a lot? If there's while brushing, whether the child bleeds from the gums, or has there been any recent trauma which can lead to hematuria. But don't forget to take information on exercise, and it's important. I'll show you later in a case about menstruation. Sometimes the first time menstruating girl child will not know, and everybody gets scared if she doesn't know, and she can panic. If there's been a recent catheterization or any history of drug intake, especially vitamin D, food colors, these can all cause color in the urine and can sometimes confuse us. So we have to look into the history very carefully. What can be the clinical cues in the history? They are very important. So as I told you that by history itself, you can figure out where to investigate, how much to investigate, and where the cause can lie. If there's periorbital puffiness, oliguria, dark urine, hypertension, edema, it's most probably a glomerular cause, and we have to look for that. If there's a fever, abdominal pain, dysuria frequency, it could be because of UTI. If there's recurrent abdominal pain, dysuria with hematuria, it could be urolithiasis or hypercalciuria. If there's been a recent sore throat or skin infection, it could be post-infection glomerulonephritis, especially post-streptococcal one. So each part in the history has importance because it can lead us to where the diagnosis can be lying. And if the child has got history of joint pains, rash or edema, it could be one of the vasculitis. A positive family history or history of deafness we could suspect Alport disease or thin membrane disease. If there's a renal lump on palpation, it could be hydronephrosis or Wilms tumor or polycystic kidney disease. And of course, bleeding tendencies are there. We have to look for these causes. And if there are recurrent episodes, IgA nephropathy has to be ruled out. So if you see, the history itself can tell you where to look for and what is the probable diagnosis in this child with hematuria. Now, once you have a child, very important that once you do the physical examination, please do not forget to take the blood pressure with a proper size cuff. And I would say not only hematuria, but any renal problem, please do take a blood pressure, whether it's UTI, nephrotic, or a lump, or any renal problem. Please do take a blood pressure. Then look for edema, purpura, rashes, any signs of arthritis. Palpate the abdomen and look for renal angle tenderness, and do look for genitalia. Sometimes these young babies, they have a very tight nappies I have seen. There's meatal stenosis and ulceration, which can lead to spots of blood in the urine, spots of blood in the nappy, and the mother can come to you and tell you that the child is passing blood in the urine. So every part is important when you examine the child. Now, once you start investigating, very important that there's such a long list of investigations that you cannot do everything in every child. So these are the basic investigations which every child would require. One is the urine examination, of course, but you do look for proteins in that and do look for any RBCs cast in the urine. Of course, we have to ask for dysmorphic RBCs, which are best done by phase contrast microscopy, which is not available very freely many places, but good hospitals have got phase contrast microscopy and they can tell you about the dysmorphic RBCs. If they are more than 20, they are significant. Then some of these children, if you are suspecting post-streptococcal, ASO titer and throat swab is required. Kidney function test will be required in all of them, electrolytes, complement C3 and complete blood counts. Then do get a urine spot calcium creatine ratio. It can sometimes give you a clue about hypercalciuria. Ultrasound abdomen is important. It has to be done for any structural anomalies, for any stones. And again, once the ultrasound is being done, I normally tell the sonologist to do a renal Doppler also simultaneously to look for the renal vessels. So these are the investigations which most of these children on first go will require. But if they are normal and you do not find any abnormality in it, then I think you should take an opinion from an expert for further investigations, which will be like expert investigation. Step 2 would be if you suspect a glomerular hematuria. How would you do that? I'll tell you a little later. Then we have to go for ANA, anti-dsDNA test, ANCA, anti-GBM, eye and ear check, and sometimes a renal biopsy is also indicated. So all these are advanced investigations which need an expert opinion also. Then if you are suspecting a non-glomerular hematuria, send urine analysis of the siblings and parents for any familial hematuria. then send 24-hour urine for calcium, creatinine, uric acid, oxalates, for crystalluria or nephrolithiasis. These children may require a VCUG, renal scan, CT, MRI, NGO, cystoscopy. So all these can be decided by the expert, and all the children will not require all the investigations. Now I'll share a very common case with you. This is a 7-year-old girl, came with passing red urine for 1 day. What further history would you like to have? If you were having a physical meeting, I would have asked you. But I would say here that the child has gross hematuria and initial evaluation in history you have taken. When will you suspect acute glomerulonephritis in this child with 1 day history of passing blood in urine? So if the urine color is dark red or smoky, or if there's oliguria, if there's early morning periorbital edema, we suspect acute glomerulonephritis, but sometimes these children may come in little sick position with the associated complications like headache, vomiting, blurring of vision, altered sensorium, seizures, or cough and breathlessness, and these are all because of fluid overload or hypertension. Again, the importance of taking a proper blood pressure comes here. These children can have hypertension with these complications. Now, in this child, we sent the urine examination and the albumin was 3+. Few WBCs were there, but there were numerous RBCs, if you can see in the urine. And there were 30% dysmorphic RBCs which had blebs, and they were like distorted RBCs which can be picked up on phase contrast. But I've seen that even an expert pathologist, even without phase contrast, can give you an idea about dysmorphic RBCs. The renal parameters were normal in this child. Potassium was also normal, but look, the complement was fairly low. Complement C3 was low, C4 was normal, ASO titer was normal in this child. So here our first impression was acute glomerulonephritis, probably post-streptococcal. But then we have to see that other causes can be there if it's not post-streptococcal one. So post-streptococcal or post-infection, we would say post-streptococcal glomerulonephritis, there's a past history of in last 2 to 4 weeks of sore throat or skin infection, and there's evidence of streptococcal infection, then we would label it as post-streptococcal. And presumptive diagnosis, first we would say, is a post-infectious glomerulonephritis, and is made if there's no evidence of streptococcal infection and the symptoms do not resolve as anticipated. I'll show you a diagram as to what are the anticipated time for symptoms to resolve in post-streptococcal one. And if they do not, then we have to look for other causes. In infectious related glomerulonephritis, usually the latent period is absent and the child comes without any prior history of sore throat or skin infection. So I was talking about the time course of and clinical laboratory manifestations of post-streptococcal. If you see, the microscopic hematuria can continue for a very long period. We have seen for months. But hypocomplementemia, C3 should come down in 8 to 12 weeks maximum. And if complement level does not come to normal in 8 to 12 weeks, then we have to think of causes other than post-streptococcal and we have to investigate accordingly. Proteinuria usually settles by 2 or 3 weeks. Hypertension settles earlier. Gross hematuria and edema also settle earlier. But look at this complement level proteinuria. If they are not settling in about 8 weeks time, start thinking of other causes where the child would probably need biopsy, and sometimes we have other causes of post-infectious glomerulonephritis, of which I will not go into too many details, but just enough to say that if you are following up the child and the child is not resolving as per the course of the clinical illness, then do look for other causes and refer them to a proper expert. Now, in contrast with it, this child has a glomerular hematuria. So in contrast with this, there's another case. This is a 12-year-old girl who has come with hematuria of 5 days and oliguria, but she has a long history of fever for last 1 month. And there are a history of joint pains and swellings of large joints for last 2 weeks. So this is a little prolonged history with gross hematuria. In this child, we have seen that the blood pressure was very high. There was facial puffiness, bilateral pitting edema, pallor was there, and there was involvement of the joints, but no fever, rash, or oral ulcers were present at present. All other systemic examinations were normal. The urine examination which was sent showed albumin as 3 plus, RBCs were abundant, and WBCs were few of them. There was a single cast, and all these RBCs were showing a lot of dysmorphic RBCs also. And hemoglobin was very low, so were platelets were also low. Renal function was grossly deranged. Creatinine was 5.8. Electrolytes, potassium was also on the higher side. So this child was a problem child, and it was not like a simple acute nephritis. The kidneys were bulky, and the complement level ANA, anti-dsDNA, and ANCA were sent and awaited. So this is another child, in contrast to the first one, who had lot of parameter derangement and a glomerular hematuria, but with a prolonged history. And in these children, we require expert opinion. And if the symptoms, as I said, are not resolving and there is a decline in GFR, so in this child, the creatinine started rising. We did a hemodialysis, we did a renal biopsy. There were more than 50% glomeruli showed crescents. They may be idiopathic or other causes, but point home I'm bringing here is that when you suspect such a case, urgent referral to a pediatric nephrologist is required, because these children would require a renal biopsy, other investigations, and aggressive immunotherapy, which may prevent progression to end-stage renal disease. Otherwise, these children, they deteriorate within days to weeks, and once these crescents have become fibrous, probably we are not able to help these children, and then they go into renal end-stage renal disease and non-resolving renal problems. So be careful when you get these children, and expert opinion is always required. So these are the two cases with glomerular hematuria. Now I show you another child who is a 10-year-old boy, a simple case, but red colored urine for 1 day. He has colicky pain on the right flanks, occasional dysuria, pain, increased frequency, urgency, strangury is present. Mother says for last few weeks or months the child has. There is no fever, no oliguria, no edema, no hypertension. So, and the urine examination was bright red in color, but and albumin was nil in this child. There were abundant RBCs and they were all eumorphic, and few WBCs. So I'm sure you all must have made a guess what this child could have with eumorphic RBCs, that is non-glomerular hematuria with no proteinuria in that, and no fever and no other constitutional symptoms. So this child's ultrasound showed stones present. There was calculi with acoustic shadows present, and this was a case with the calculus, and the hematuria was secondary to that. So this was a non-glomerular hematuria. So once we see a child with approach to a gross hematuria would be that I've shown you two large groups of children with gross hematuria. One is with the glomerular and the other is non-glomerular type. So it's very important that we need to distinguish between these two groups of glomerular and non-glomerular, because the investigations and your diagnosis will rest on them. If you see the glomerular, if you see the urine is very brown or tea color or cola colored, it's probably a glomerular hematuria, and non-glomerular hematuria is usually bright red like this. Proteinuria is usually present in glomerular hematuria and absent in non-glomerular. As I said, dysmorphic RBCs are seen when seen, they are reflecting glomerular hematuria, and RBC cast present glomerular hematuria. But if there are crystals present, then they would reflect non-glomerular hematuria. So once you differentiate between these two, you can go into the causes of glomerular hematuria or non-glomerular hematuria and investigate the child accordingly. That simplifies the thing. So if I sum up till now, that you have seen blood, you have done the dipstick, blood is present, no RBCs, hemoglobinuria or myoglobinuria. If RBC is hematuria, if hematuria, see for glomerular or non-glomerular hematuria, and then go for causes of each of these separately. Now, a few more cases which I have come across in my practice and of general importance, because they can sometimes be ambiguous and lead to confusion also. This is an 8-year-old child, Amit, who was passing red-colored urine for last 3 months. This child was referred to me from Kanpur, And this child had been seeing so many pediatricians all over Kanpur and Lucknow. Lot of investigations done, but cause was not found for hematuria. And the history revealed he had intermittent once in every 10 to 12 days for 2 to 3 days. So look into the history that every 10 to 12 days the child had hematuria lasting for 2 to 3 days. This was painless. There was no fever, no rash, no joint pains, no history of dysuria, no increased frequency, no periorbital puffiness, no edema, no oliguria. So we are ruling out causes of glomerular hematuria, acute nephritis like things in this child, but the history here is a little different uh, compared to the previous cases, that this child has got recurrent gross hematuria. So once we investigate these children, detailed history was taken, and I looked at the big file which the child had brought, studied that for a day, and then called them back, and detailed investigations of urine and blood and other ultrasound were done. They were all within normal limits. And once I took the history in detail, this child was an avid football player. When he played for 2 to 3 hours, there was hematuria started by evening and it persisted for next 2 to 3 days. Then I asked the child, what does happen if you play for a little while? He says, Uncle, when I play for half an hour or so, then there is no problem. And this was a case which was clear-cut case of exercise-induced hematuria. So here we do not need to give any medications, further investigations, and treatments to these children. The only thing is that it's an exercise induced, and we have to counsel these parents and children that they have to do the exercises, but do within the limits so that the child doesn't have gross hematuria. Another interesting case came from nearby Haryana, Soni Panipat or Karnal somewhere. The mother was very intelligent. She noticed blood on the washroom floor after use by the child, and she took a picture and showed it to the pediatrician, who could recognize that this is blood in the urine. So the child was seen and then referred. When I took the history, the child was 5 years old. There was passage of red colored urine off and on for last 6 months. The child had seen this red colored urine but never told the mother because he never knew that this is abnormal. But when the mother noticed on the floor of the floor and took a picture, then we realized that this is blood in the urine. There was no history of dysuria, fever, colicky pain or rash. Family history was not significant. What was important in this child was this child had leg pains and was seen by 2, 3 orthopedicians who had given him vitamin D shots, injectable 6 lakh shot, multiple shots. He had taken oral vitamin D and calcium also. And he was taking a lot of gummies of vitamin D, which were very tasty. So the mother said, "ये तो 8-10 रोज खा जाता है gummies," and he was taking calcium. So when we investigated, the physical examination was normal, but urine showed protein was nil. RBCs were abundant. They were all eumorphic. That means there were non-glomerular hematuria. Blood and X-ray and ultrasound were all normal. What was significant was that calcium creatinine ratio was very high in this child. Against 0.2, it was 0.48, and 24-hour urine calcium was very high, 6 milligram per kg, against a normal of 4. And vitamin D was significant, very high, more than 500 micromoles. So this was a child with hypercalciuria secondary to hypervitamin doses D. So why I brought up this case was that all our pediatrician friends, physicians, everybody is using vitamin D left, right, and center. But we must be very cautious when we are giving vitamin D. Take a history that the child has received vitamin D earlier or not, and what is the level, and then according to that prescribe vitamin D. And we are getting, all of us are getting cases with hypervitaminosis D, and it is being used indiscriminately, if I would say so. Now, we have finished with the gross hematuria. I've showed you a number of cases with glomerular, non-glomerular hematuria, but sometimes we come across microscopic hematuria only. And how do we see that? The child's urine has been sent and there are more than 5 RBCs per high power field, and they are persisting after 2 to 3 weeks also. So here I show you a case with microscopic hematuria. This is a 4-year girl, initially had edema, feet, and a sarca. There was pitting edema, proteinuria was there. There were RBCs, 50 RBCs per high power field. Protein creatine ratio was very high. Serum albumin was low, cholesterol was high, and this was a child typically as nephrotic syndrome. And we gave him a course of prednisolone, full course of prednisolone for 4 weeks first. But at the end of 4 weeks, the proteinuria was persisting, and so was hematuria, and the blood pressure has increased further, which could be secondary to the renal disease or also because of steroids. So this was a child who required a biopsy because this child was steroid resistant nephrotic syndrome. And on the biopsy, we were suspecting that there is something different and not minimal change. And this came out to be focal segmental glomerulosclerosis. So point I'm bringing home here is that in children, sometimes you see microscopic hematuria and nephrotic, but if there are resistant nephrotic, steroid resistant nephrotics, then please take an expert opinion. These are the children who would require biopsy if the hematuria or proteinuria is persisting in these children by the end of 4 weeks. Then another child with microscopic hematuria is a 4-year-old girl who came with fever. Essentially, examination was normal and urine albumin was traced, but there were a lot of RBCs, 250 to 300 RBCs. Blood ultrasound workup was all normal. In follow-up, the urine RBCs were persisting, and then this child was referred to me for evaluation. And when I saw him at the end of 6 months also, the child albumin was slightly increased and RBCs were more than 500. There was detailed blood workup was done, which was normal. Eye and ENT checkup was also done, which was normal. So I counseled the parent that this child would require a renal biopsy, and a kidney biopsy was done. And in light microscopy, there was no abnormality. Immunofluorescence was negative. But on EM examination, electron microscopy, it came out to be thin basement membrane disease, which was causing a microscopic hematuria, which was persistent in this child. So again, a point to bring home is that if the child has got a persistent microscopic hematuria, which is lasting beyond 6 months, then these children would require evaluation and maybe further biopsy may be required. Not moving further. So if you have an asymptomatic microscopic hematuria, not moving further. Yeah. So if you have isolated hematuria, repeat after 2 to 3 weeks. If it is persisting, then review at every 2 months with careful rotation of the history and special emphasis on family history. And do examine the urine and the child for edema, hypertension, especially proteinuria, see for renal function test and other family members. And in 60%, there would be spontaneous resolution. But if it is persisting beyond 6 months, I would say, then we should investigate this child. And significant renal disease does not exist in those with hematuria alone, microscopic hematuria alone, unless they have other things which I'll show you. If they have those, then the child may be referred for further. If the child has proteinuria along with microscopic hematuria, there's a long list of diseases which can cause this, and they need an expert opinion and sometimes a renal biopsy. Management I will not touch because this depends on the cause, and there was a separate lecture in almost every disease. What I would now do is take home message. That's the last slide. And we would still reiterate that the commonest cause of glomerular hematuria in our country still is post-streptococcal or post-infectious glomerulonephritis. Those with rapidly progressive glomerulonephritis or glomerular disorder other than post-infection will need a renal biopsy and an expert opinion. Common causes of non-glomerular hematuria are still calculi and hypercalciuria. Presence of microscopic hematuria and proteinuria portends a significant disease and may need a renal biopsy. Recurrent gross hematuria with no obvious cause need to be referred for expert opinion. Asymptomatic microscopic hematuria needs to be kept under surveillance and most of the time the resolution will occur within 6 months. If not, then please refer to an expert for opinion and further investigations. So these are my two books which Dr. Ney had already pointed out, and there's a chapter on hematuria in both of them. And for your pediatric nephrology reading, I can recommend you to go through this IIP Specialty Series Pediatric Nephrology book, which is authored by almost 40 top-line pediatric nephrologists of the country, and it has got a chapter in almost every disease in renal problem, and you can take guidance from it. Thank you very much. And with this, I would end my talk and stop sharing these slides, and we can go on to the main platform. Right. Thank you. Over to the experts and the chairperson and Dr. Neha. Thank you.
Thank you.
I think I am well within time. 30 minutes, 35 minutes, right?
Yes, Dr. Shubhankar to.
Okay. Thank you, sir, for every details and presentation. I think you covered all these most common and most practical problem we face in day-to-day basis. I just add few causes. So in our ward, we face 2-3 kids actually. They present with a gross, stain genitalia with the blood for a multiple episode, and then work up in a OPD and didn't find any cause actually. But they saw the report of more than hundreds of RBC, and child is absolutely fine clinically. So we admitted those kids. And after admission, keeping in 2-3 days, there is no episode of hematuria. So I just pointing out to you, you also face that something is called Munchausen by proxy. So it's happened. If you took the family history, and both of these kids has a good family risk factor is there. And we discuss, we explain, we have a psychological intervention, then the child is no more coming to our OPD, and hopefully they are not going to the other hospital also. So this is one of the issues to be fixed before you go to the details, more costly investigation. And other few points like regarding the supplements. So vitamin D, definitely it's a oral and whatever actually using the market, even the parents used to take from the over the counter to say that it's a very good role of vitamins. So that, as you have explained very nicely. So other vitamins like multivitamins, that is also, it's practiced by the doctor also, and the family also feel that my child is weak, you should give some vitamins. So it presents like that vitamins, multivitamin also contain a lot of vitamin D and calcium, and plus they can present it with one of the questions is there in the chat box that can present with the discoloration of urine. So mostly vitamin D, multivitamin cause yellowish urine. That is mostly is because of the vitamin B12 actually. And other supplements like during Corona period, we took a lot of vitamin C. And you know that nowadays the trend is going on in social media that if you took the vitamin C, your skin is going to be so, so nice and clean. So people are using in adolescents, those are very body conscious, they are taking a lot of vitamin C. So they could have a hyperoxaluria and hematuria also. So this is the, but they never going to say that I'm taking vitamin C. So this is the practical point you should definitely explore. And another most important point is the surgical cause. I think we should also see many a time we thought that it's a benign, it's episodic, painless. So we need to call the urologist or pediatric surgeon to see the bladder. I need a scope to see the bladder. We have a few kids, they have some hemangioma and polyps. And you also definitely look the local area like balanitis, the stricture, and the preputial adhesion. So that can cause also a recurrent episode of UTI or hematuria. So I would say these are the very simple intervention before jumping to the costly investigation. You can catch the disease. The gross hematuria, it's definitely, don't say the easy to pick up, but the family is so worried. They will reach the doctor. If there is no diagnosis, they can jump to the another expert, to the another expert. So ultimately, they will reach a particular diagnosis. So gross hematuria, not so neglected in the form of diagnosis. But the microscopic hematuria, many times, just you saw the child, the bring with the big file. So that's happened actually. So when reach a expert like pediatric nephrologist or a senior pediatrician, they will very worried. So many papers is there. How can I handle that? Because I have a busy OPD. So in government and private, those who are very expert, they have a lot of patients to see, but you can see the bunch of paper they will bring to you. And definitely I see many times most of the workup is done, but interpretation either miss or somewhere some problem, you can reach the diagnosis by doing 1 or 2 tests. So I think that interpreting the report, taking good history, definitely clue toward the microscopic hematuria. But still, I'd say the managing or reaching the diagnosis of microscopic hematuria still is a big headache for the doctor. I mean, we have a few kids. We did a lot of work, including genetic biopsy and everything, but we didn't reach the diagnosis. And we are still repeating the test to look for hypercalciuria and other anomalies is there or not. But definitely, the idiopathic microscopic hematuria still, it's a problem for in our community. And many time, even we reach the diagnosis, don't have the treatment also, like collagen chiasm disease. I mean, that is another issues to be looked into. Another most common problem, I would say, you definitely look for the constipation. So constipation guy, a child could have some form of hematuria because these both axes working together in a same neural pathway. It can give you a falsely kind of picture of hematuria and associated combined anomalies that can cause causes of hematuria. Little about the nephrotic syndrome. Definitely, classically FSGS, those were like late presentation could have a hematuria around 10 to 30%, I would say. But we also see some patients with the membranous nephropathy. Some patient of the minimal chain disease could have a hematuria also, and also sometimes like C3GN, they could have a hematuria. So these are the atypical presentation of the nephrotic syndrome. Definitely send to the expert for the biopsy and proper diagnosis to prognosticate the future. And I think that is more from my side. And then we can go for discussion to look further questions and answer.
Thank you so much. I think answered the question. There are only just one thing that sometimes the very rare causes like nutcracker can be there at
Yeah.
times without everything. So it would be a good idea when you do a CT scan, you should always ask your radiologist if it is a nutcracker, but they mostly present with gross or microscopic hematuria. But it's basically, I think you rule out everything then only. So I think wonderful presentation. We've
I
already
think you had a case when we had come to Akash Hospital. Your
we have operated.
urologist had presented a couple of cases of nutcracker syndrome with gross hematuria, and they were operated also. Though uncommon, but then they should be looked into when there's a recurrent gross hematuria, and we have find all other investigations normal. So whenever I refer for CT to the radiologist, I also tell the radiologist what I am looking out for, so that they can focus on the main part of for nutcracker syndrome, for entrapment of renal vessels. That's important.
Dinesh sir is there.
Selva, Dr. Selva is there. Dr. Selva, are you on this platform? Dr. Selva can, he's from Malaysia. He's a pediatric nephrologist and was the president of Malaysian Pediatric Association.
In the Q&A, green urine.
Okay, right. Green urine was interesting because the mother came with the history that the child is passing green urine, and she actually brought a sample, morning sample in a bottle, and it was green colored. So I asked if there's any history of fever or UTI, because one bacteria, Pseudomonas, can cause greenish color urine, but normally not that dark green. So I asked the history, but there was no fever or nothing. So I asked the mother that let me see a fresh urine. So I got a fresh urine done, and that again was little lighter than the previous, but again green colored. And I made the child wait for an hour or so, and after that gave him some drinks and water, and again got the urine, and the color became still lighter. So I was suspecting that probably it is not disease related, there is something else. And in the history, I couldn't get anything. But when I talked to the child, this child was taking lot of candies which were green colored candies, and this was the reflection of the food color which was coming in the urine. And previous day there was some sort of a party where the child had taken lot of these green colored candies and other stuff which was like sweets. And then I told the mother that don't worry, wait till tomorrow and let me see the color. And gradually the color faded and the child became normal. So again, a learning point that at times we have a very different presentation where actually it may not be related to any disease, but we have to look into the history. History again is very important, and once you spend time in taking the history, one more child came to me, was referred in a frantic way that the child is passing red urine from a pediatrician who had not seen the child but referred directly to me. They came with a urine which was high colored urine, dark yellow, but not red. So I said, probably the child is taking less water or so. Let me send this urine for routine examination. And I asked the pathologist in the hospital to give me a quick report. In the meantime, I asked the child to take some water, and the color became lighter after about half an hour. In the meantime, the report also came, and there were no RBCs. When I took the history, the child was having upper respiratory infection, was taking a medicine called T-Minic, which was orange in color, and this was a color because of the medication, which led to panic in the family, and they thought it is blood, and they came directly to me, referred by pediatrician. So at times we have to take the history, look into it before, as Dr. Shubhankar said, that instead of going into detailed investigations, look into simple things into the history and microscopic examination. Do confirm whether it is actually hematuria or not, or there is some other reason because of which the color is changing, and the child can be saved from detailed investigations.
I think, sir, we are already over the time. I would request Dr. Dinesh, sir, are you there? Ravinder, sir?
Or Dr. Kanav is there?
Dr. Suprita is there with us.
Or if she wants to make any comment, Ranjit is also there.
Yeah.
If they want to share any experience, we still have about 3-4 minutes with us.
So, good morning, sir. Firstly, it was such a good and practical presentation that there's very little to add on really on top of that. One small experience I wanted to share was that looking for deformed RBCs, one kind of via media which we can do when we don't have phase contrast microscopy, we've tried using oil immersion. And the RBC shows small blebs. One old paper talked about D1, D2, D3. I've attempted it in my hospital with limited success. If the pathologist is on board, we can do it.
Right. I think an experienced pathologist can look for dysmorphic RBCs, and at times I've had experience with good pathologists, and they can tell us that yes, there are dysmorphic RBCs, and we can direct our investigations towards that.
So adding to this, what Dr. Ranjit has said, nowadays a lot of labs are doing flow cytometric urine analysis. So as a part of normal urine routine also. So in that they usually comment about isomorphic versus dysmorphic RBC as a part of the regular check. So we need not do it specifically because that's part of the analysis.
Flow cytometry, I think
Yeah,
some of these good labs.
Some of the labs are doing it, yeah.
Right.
Nice. From the pediatrician perspective, if there's a couple of labs nearby also, they said you want a 50 rupees urine routine or a 150 rupees urine routine. So that's the difference. So 50 rupees is that basic one and 150 is the flow cytometric urine RM.
Right. In Lal Path lab, they say routine urine examination and enhanced urine examination.
Enhanced, yeah.
Yeah, enhanced, and so they give these detailed. I think that's a good information. Good information.
The
Right.
second thing regarding overdiagnosis of hypervitaminosis D. Because what I've seen in my practice is nowadays even a lot of labs are doing packages. So you would have written them 5 tests, they would have done 100 tests because of the package. So there what problem occurs is for the past, if the last report was showing hypervitamin D and you have just given them 2 shots, your plan was to give them 8 shots weekly, but you have just given 2 shots and the parent goes and does another package again. So just with 2 shots, the values will be pretty high. But then you should go into that history of how many shots did you take and when was the last shot when you did the test. Because if it's just taken a day or two before, the values will be pretty high and will be overdiagnosed as hypervitamin D just because he has just given the dose and then he has done the testing.
Right. Practical point, yes.
So I think, sir, Dinesh, sir, I think he's already there. Sir, are you there? Sir, I think we can end now. Yes, we've already run out of time. If anybody else wants to make
Yeah,
it,
Dr. Dinesh, I think he's, I can see his tab, but he's not visible.
maybe he's not able to join us.
Right, okay.
Thank you.
Maybe
Thank
some
you so
technical.
much, everyone. Vasudev sir, Shubhankar, and I would say Shubhankar because he's my batchmate.
No, it's not a batchmate. So we did a fellowship same time. She's senior to me actually, definitely. So we did a fellowship in Singapore for, I think we spent more than 6-7 months there actually.
So, and thank you, Kanav sir, for your insights, Dr. Ranjit, Dr. Suprita, all the faculty, Dr. Silva. Thank you so much for the wonderful session. We already are getting messages from the delegate group that it was a wonderful session, sir. Thank you very much.
Thank you very much. And thanks
Dr.
to
Dinesh.
all the participants and also the faculty. And it was a pleasure to be with you. Thank you.
Thank you.
Thank you, sir.